everyone. I'm Erica. I'm one of the staff specialists at the Mater. These, unfortunately, are not my slides, so I apologise if I'm not as fluid as I should be going through them. I stepped in at the last minute. So, palliative care services across Hunter, New England is quite variable. So I'm just going to go through reasonably quickly to give you a bit of an idea about what's available and where. So the service provider, the actual person who would provide palliative care to you face-to-face varies depending on where you live. So as you know, it's a really big area. And there are 22 palliative care service providers across the district. Okay, so very different whether you live within 5 k's of the Mater or whether you're way up in the top of the valley up near the border. So it just depends based on what your home address is as to actually who will provide that palliative care. If you're an inpatient, and that can be in any hospital, there is capacity to do inpatient consultations. If you're in a private hospital, that can often be supporting the doctor who's looking after you. Palliative care services may be able to come out to certain hospitals. Once again, it'll depend on your location. Nursing consultations, we have some specialist nurses based here in the Mater, and there are specialist trained nurses in some other areas, but once again, really variable as you move out into the more regional and remote areas. Allied health services, they're mainly based in the larger hospitals. There are some attached to community health services. Once again, reasonably variable depending on the location that you're in. Obviously, larger centres are better served for allied health support. Research and education, they tend to congregate in the larger services, but there's often people in smaller regional areas who are really well connected to larger research groups in the bigger hospitals. As an outpatient, you have access to community palliative care, and they often work alongside community nursing services. So often it's the community health unit of your local or regional hospital that will manage that. Once again, they have allied health, slightly variable depending on where you live. Outpatients clinics, so often if you are regional or remote, you can come in to the local centre, often in the healthcare district or around the hospital. We can go to an outpatient clinic. We run an outpatient clinic at the Mater too, and some people come quite some distance to attend that outpatient clinic if they need to. We have telehealth capacity, and that's particularly useful for people in regional or remote areas. So if the nurse or the doctor looking after you is struggling with your care, then they can get some telehealth support through from the specialist unit at the Mater. We do have based at the Mater a day program, Big Tree Day program. Unfortunately, just with the COVID issue, it's been on hold recently, but we do have a day program where people can come in to the specialist unit and be with other people with similar issues, but also have access to some of the activities that run through there. As Lindy mentioned, we have bereavement support programs. There are some of those in other regional hospitals, but there's a significantly sized unit at the Mater, and active research and education. So in regional areas, the palliative care service tends to be nursing-led. So at the Mater, it's physician-led, but in other areas it tends to be nursing-led. The inpatient unit at the Mater is the only tertiary palliative care inpatient unit out in New South Wales outside Sydney. So there's not a lot of inpatient palliative care, but a lot of hospitals have palliative care beds. Okay, so they have beds that are particularly set up, staff that have a particular interest, and they can receive support from the Mater unit if they require it. Regional hospitals tend to rely on general practitioners to admit. Sometimes they have visiting medical officers and certain physicians who come and go, but often in those smaller hospitals it's the GPs who will admit you if required, and we can support them either via telehealth or via phone as we need to. If your symptoms are not able to be managed in whatever service you're in, they can ring through to the service at the Mater, and we can either give advice there, or if necessary, we can bring people through to the MATA if we're really struggling with symptoms out in some of those regional areas. That's actually quite a rare scenario. Normally regional hospitals are incredibly good at managing sometimes really quite complex symptoms if they need to. But if there's a real problem and your care just can't be managed, then we can organise to bring you through to the MATA. If you're an inpatient in Belmont or the John Hunter Hospital, then we have a consultation service. So we have staff specialists in palliative care based at the MATA who go out to those hospitals. At the John Hunter, we have a strong nursing presence. We have 2 nurse practitioners and a very experienced CNC who's based in the John Hunter, and they can see patients with palliative care needs. Usually it's referred by the doctor that they're admitted under. They can go and see those patients and help with symptoms during the admission, but also help with discharge planning. So if those people think that you need help continuing after discharge, that can be organised while you're actually an inpatient. So our involvement with patients in other hospitals is really variable. Sometimes it's an in and out service. We go in, sort the pain out, and we're gone, and it's all okay. Sometimes it's more intensive. We might see people multiple times during the admission until we get things right and then follow them up as an outpatient. Sometimes it's more intensive again, and we might talk to the clinician that's involved in their care, and there might almost be a transition of care across to a predominantly palliative care paradigm. So we try not to do anything suddenly. We often walk alongside other clinicians as part of your care, and that's a really important concept. It's not you go along with your oncologist and then one day, bang, that just stops. It's a transition. Often we'll come in initially with symptom control, some advice about perhaps it's nausea, perhaps it's pain, perhaps it's seizures, perhaps it's something else, and your oncologist will remain driving the bus, if you will, and then over time, for some patients, we become the main source of care. At home, once again, the exact provider will depend on where you live. So the degree of support that you get, the type of support that you can have at home, does vary depending very much on the location. The referral to that can come from your GP or can come from a doctor that you were admitted under in a health service. Quite often the way it happens is that a family member will be concerned and will speak to perhaps the community nurse or speak to the GP, and that's the way that we'll get a referral for you to follow you up in the community. At home in Newcastle, so I think it's a 20k radius, Cindy, of the hospice. We have a palliative care outreach service. We have a 24-hour phone support line, and those on the end of the phone is a really experienced nurse who can give you or your carer some advice about what to do about your concern. We are not funded to be an emergency response unit, so if you need help right now and something awful's happening, 000 is still the quickest way to get urgent support. Okay, so it's not an emergency response. It's really a service that's looking after your symptom control. If things are changing, if someone's concerned about you, if things aren't going as well, that service can give phone advice, but they can also organise a visit out to home and try and optimise the symptom management as well as we can in the home environment. We do triage requests that come in, so when you first get referred to the service, you'll get a phone call. There'll be some questions, we'll try and get a feel about what's happening, and then that will be triaged just like in the rest of healthcare. Does someone need to get out there today? Do we perhaps need to bring you into hospital urgently? Can we send a nurse out in a day or so? Can we get a nurse out in a week? Do we need one of our doctors to go? So it's slightly variable depending on how it's assessed and what we think is going on. The main aim of the palliative care outreach service is symptom control. Okay, so we're really focused on how are your symptoms day to day, what's your quality of life, how can we optimise that as much as we can. So it's really a lot of symptom control assessment and managing medication changes at home. If you choose to have your end-of-life care at home, then that support could be really quite intensive. We can run medications under the skin through infusion pumps at home. We can train carers to give injections for symptoms if needed. So there's some pretty intensive management that can be done at home with our support if that's the decision that you want to make. But we're not a hands-on nursing service in that we don't do wound dressings or come and give showers or feed patients or sit with patients for hours. So that burden of care, it really rests with family. The palliative care service doesn't provide that. So for the majority of patients who are really quite unwell at home, you may need to consider other services. Community nursing is one of the ones that's frequently used, the NDIS, if appropriate, some My Age care packages. And often there are planners and providers who can work out the best package. And for you guys, we've got some wonderful services who can help you work out the best package of care going forward. So palliative care is really involved with symptom control and medication management and then end-of-life care if that's appropriate. The hospice, and a lot of people go, oh gosh, you know, that's a scary thought. I think people often think that everybody who comes to the hospice dies. About 30% or so of patients who are admitted to the hospice are discharged alive. Okay, so we do optimise the symptom control for patients and get them home. Okay? A lot of people do come in for end-of-life care though. So it's run by palliative care specialists, we have specialist nurses, we have allied health. We're actually quite lucky in the large sort of allied health multidisciplinary team that we have. We have 17 funded beds. Sometimes I think they're sitting at 20 today because it's pretty busy. They're not all single rooms, they're majority single rooms. Okay, and we optimise, if somebody's reaching end of life, often we try and get those people a single room, but there are a couple of shared rooms. One of those rooms in particular is people who are agitated, who require extra supervision. So just so you know. 3 main reasons for admission. Symptom control is by far the biggest one. So somebody who may have trouble breathing, may have trouble with anxiety, may have trouble with pain or nausea. If it's not well managed where they are, and that's wherever they are, whether they're at home, whether they're in Cessnock Hospital, whether they're in the John Hunter, wherever it might be, if we're not winning where they are, we can bring them in and get that under control, and then they can go back to home if they're able to manage, go back to their hospital closer to family if that's appropriate, or stay in with us. So symptoms are the main one. We do have beds for respite care if carers just need a break. We don't have as many as we perhaps like. If we had an endless pit of money, we would have more of those sort of beds just to give people a break. And the majority of patients who come in don't want to come in initially, and then after they've been with us for a day or so, they go, gee, if I'd known it was like this, I would have come earlier, and I'll come in a few weeks to give my carer a break if I can. So that's a service that we love to provide, we'd like to provide more. And then end-of-life care. Certainly if that's not something that you want to manage at home or you can manage at home, then we provide end-of-life care at the hospice. So you have to agree to a couple of things to come into the hospice. The not for resuscitation is probably the biggest one. So like Lindy said, we're not aiming to either shorten or prolong your life. And the thought for patients in the hospice is that trying to resuscitate someone would actually cause more pain and suffering and would not give any meaningful outcome. So we're not set up to offer resuscitation, and if you want those things, then hospice is not the right spot for you. You need to understand when you come in that we're not a long-stay facility. So if people are stable for a prolonged period, and it's not just a few days or a couple of weeks, but over a prolonged period, if you're stable, even if you're still quite unwell, but if there's no medical or symptomatic concern that we're having to do clever things about, then the powers that be in our institution won't let us keep people for a prolonged period of time. So there are patients who need to have a plan of where to from the hospice if home isn't a possibility. And for some people that's a nursing home. For some people it's other sort of peripheral hospitals. Sometimes people can get out of the Mater and go back to smaller hospitals near home. There's not quite as much bed pressure, but unfortunately, we would love to be able to keep people, but we can't always. As Lindy said, the focus is on living rather than on dying, and we have some nice little things that we can do at the hospice that are more difficult in routine places of hospital care. Probably having your pets in to visit is one of the big ones. So cats, dogs, we've had goats, we've had a horse at one point. The horse was pretty amazing. We've had sheep, we've had all sorts of things. So we try and help patients and families as much as we can if that's important to them. It's a surprising number of people where that's a really important thing. We do have a drinks trolley, which is nice. And we have gate leave. So if you're well, if you're having a great day and you want to go out with your family, then we will facilitate that as much as possible. We organise special events quite often at the hospice. We've had multiple weddings there, and we've had some really big family gatherings. We've had some special events in people's lives that they've chosen to celebrate with their loved ones in the hospice. So it's something that we try and do as well as we can. And importantly for a lot of patients, there's a fridge in the room and you can access the outside world from each room. So is it home? No. Is it closer to home than a 4-bedded ward in one of the big hospitals? Yeah, it is. And we do our best to make sure. I think that's it. Thank you very much.